Today, I'm excited because we have a somewhat new face joining us, which is Lexi. Lexi Nussbaum is a student who will be working with Charla Rent on her master's project. And this is a bit of a proposal of that work. So I'm sure that you'll be open for feedback. We will be nice. But without further ado, I'm sure you'll explain it all to us. So I'll turn it over to Lexi. Welcome.
Thank you, Ashley, for the introduction. My name is Lexi. I am Master of Global Health student at DGHI, working under Charla Rent, and I'll share my screen now. Okay. Can you see that and hear me okay?
Yep, looks great.
Okay, perfect. So like Ashley said, today I'm going to be presenting my master's research proposal, and that will be identifying the barriers and facilitators healthcare providers face when responding to obstetric, neonatal, and pediatric emergencies in Kilimanjaro, Tanzania, and this will be a qualitative focus group study. So it's currently known that maternal and child deaths are largely preventable with quality emergency care. There are current tools available for quantifying the ability to manage such emergencies, one of those being the WHO's Hospital Emergency Unit Assessment Tool that is focused on adult emergencies and has been employed previously in Tanzania and other LMICs. But current data from tools like the WHO HEAT do not adequately assess maternal child health emergencies, as it only includes a few broad items for maternal child health care, and it overlooks specialized emergency units. So the long-term goal with this project is to provide a more comprehensive data set on facility level and provider level maternal child health capacity across the Kilimanjaro region, potentially leading to life-saving interventions. And we can reach this goal through identification of barriers through a focus group study. I will refer to maternal child health emergencies frequently throughout this presentation, and I will define it now as an emergency condition that affects pregnant women, postpartum women, newborn infants, or pediatric patients that are less than 18 years old. Big picture, emergency work globally currently focuses on adult emergency, and it doesn't necessarily capture pediatric illness. Pregnancy-related work is also not well captured because mother and neonatal emergencies are usually transferred to OB wards, and therefore they're left out of emergency data. Our study will feature both a quantitative and a qualitative portion. The quantitative portion is using a revised version of the WHO HEAT, which is called the MCH HEAT, to evaluate the capacity of facilities in the Kilimanjaro region to respond to obstetric, neonatal, and pediatric emergencies. And this project is currently in progress. The qualitative portion will use focus groups to help describe facilitators and barriers healthcare workers experience in responding to such emergencies. In this presentation, I will focus on the qualitative portion, since that's what I will be conducting my master's thesis on. And the qualitative side will help provide the human element as to how it feels to deal with maternal child health emergencies frequently, as well as how healthcare providers can provide support to each other and to families. So through the study, I hypothesized that healthcare workers in the Kilimanjaro region encounter significant barriers to effectively responding to maternal child health emergencies, primarily due to inadequate staffing, limited availability of specialized equipment, insufficient training, and systemic issues such as delayed referrals and lack of standardized protocols across facilities. I also hypothesized that providers who frequently manage maternal child health emergencies experience increased mental health challenges, such as higher levels of stress, anxiety, or burnout, and they will report varied emotional responses to death, potentially influencing their coping mechanisms and professional practices. This study will also help address gaps in literature by focusing on both facility limitations and provider experiences. Primary objective of this study is to identify barriers and facilitators related to effective maternal-child health emergency care. And specifically, this can be split into 3 different aims. Aim 1 being to assess the facility level resource and human resource challenges. And this aim can help identify key limitations within health facilities, such as shortage of staffing, insufficient training, and adequate equipment. And aim 2 will evaluate the mental health challenges faced by healthcare providers in response to patient death and emergency situations, and can help identify specific mental health barriers and coping mechanisms utilized by providers following adverse outcomes. And finally, aim 3 will assess the current ability for providers to give psychosocial support for families in the face of maternal-child health emergencies. This study will take place in the Kilimanjaro region of Tanzania, specifically across 20 health facilities, including primary, secondary, and tertiary healthcare centers. I'll be utilizing current GEMINI team infrastructure and will be on site for 2 months this summer. And the target population is healthcare providers who manage maternal, neonatal, and pediatric emergencies, which includes physicians, nurses, and midwives. A study team member will work with the hospital leaders to identify eligible and interested participants from each clinical sector. Focus groups will occur after the MCHE, which is the quantitative portion of the study, has been carried out at any given site. Inclusion criteria includes adults that are greater than or equal to 18 years old, Kiswahili speaking, working in the current facility for at least 1 year, and have clinical experience with the target population for at least 2 years. Moving into study design, this is a qualitative descriptive study that will follow correct guidelines. We've identified 20 sites that were chosen based on frequency of transfer of relevant obstetric, neonatal, and pediatric patients based on consensus opinion of clinical leaders at KCMC. 3 focus groups discussions will occur at each of the 20 sites, 1 with a focus on obstetric emergencies, 1 with neonatal emergencies, and 1 with a focus on pediatric emergencies. Each focus group will include 6 to 8 providers, of which 3 to 4 are physicians, 3 to 4 are nurses, or midwives. A trained facilitator fluent in Kiswahili will lead these sessions. Participants will be assigned an anonymous identifier and will discuss open-ended questions addressing lived experience. Data sources include audio recordings and field notes that will be stored in RedCap, and then thematic analysis will occur using Deduce software. Our focus group guide is split loosely into 5 sections, of which I've given examples here. These sections include management and responses to emergency scenarios, referring and transferring patients, unique emergencies, caring for families after a bad outcome, and finally caring for themselves, the healthcare workers, after a bad outcome. The examples you can see here are, let's have a few people share their experiences about an emergency situation that you feel you were unprepared for. What was the scenario? Why did you feel this way? What delays might a patient experience during transfer? And then tell me about how you talk to the family of the patient after they die. Who talks to the family? Where does this conversation occur? And how do cultural or religious beliefs of the patient's family influence how you approach conversations after a death? What support do you think is needed for families? Is this available? And how does working with emergency scenarios, seeing very sick or injured patients, some who do not survive, affect you after you go home? By using focus groups to gather these perspectives, the study aims to produce a comprehensive understanding of the obstacles impacting maternal child health emergency care. If successful, this study will inform targeted interventions to improve both the operational capacity of healthcare facilities, as well as the psychological support available to both providers and families, which will ultimately contribute to better care outcomes for mothers and children and foster a more resilient healthcare workforce. Possible risks may include emotional discomfort due to discussion of challenging experiences that may evoke distress, as well as potential confidentiality risks between the individuals within the group discussion. The topics may also be unfamiliar to participants, so they may not have the language or history to describe their experiences. Minimization strategies include voluntary participation, in which the individual can leave at any time. And as for confidentiality, each participant will be assigned an anonymous number that will identify them only to authorized research personnel. Using focus groups can help normalize experiences as well, which can encourage others to share. Before we get into questions, I'll just give you an update on where the study is at. It's on its second review with the NIMR, which is the National IRB of Tanzania. So we're hoping to launch it this spring, with me doing active data collection alongside the team this summer in Kilimanjaro. So my questions for you guys is if you have any advice for taking field notes during focus groups or advice for successful focus group discussion. And then if you have any questions for me, I'm happy to hear them as well.
Really wonderful. Thanks, Lexi. We can't all go at once. If you have questions or answers for Lexi, go for it.
I'm going to ask our team in Tanzania, can you give her some suggestions on how doing field notes and qualitative work, how that's worked really well, what your experience has been? Rosalia, Winnie.
Hi everyone. Thank you, Lexi, for a very nice presentation. I'm excited because I know you're going to work together on this when you're here. Advice on doing a focus group discussion here. I'm going to say, as Catherine normally says, it depends. Yeah, it depends on the people you're actually interviewing. So, but taking notes can be overwhelming, but if you're 3 of you doing the interview, then 1 of you can do the note taking. And on the part of I'm glad you've talked about de-identifying the participants. So also while you're talking to them, you can give them names that they'll be using, or like labels that they'll be using as names to avoid their names being heard in the audios. I think there's a lot, but we'll talk more when you're here. But it depends. So we'll see as we go. You might modify your the way you want to proceed with it as you go. So you can do the first one and see how it goes. Then you rectify as you go. Thank you.
Thanks, Rosalia.
Well, congratulations, Lexi. That's a good study and a good presentation. From my experience, from the qualitative work I did, one thing you should expect is the difference when you're trying to get response from Tanzanians. We are not the type of people who would speak openly or have the confidence to speak. So in the beginning of the interview, expect people to be very quiet, to be a bit scared to share their opinions, To avoid this, it's very important to build a very good rapport and make sure people are comfortable before starting your qualitative interviews. And also, people are scared of voice recorders. Sometimes they think it might be used for government purposes or security, or it might affect their work, what they say. So it's also important to assure them that what is being collected is for better health outcomes of them and their loved ones and the community at large. Thank you.
Thank you.
Excellent advice.
William, Edwin, Timothy?
Okay.
Yeah, so
You can fight over
go
it if you want.
go on, William. Go on.
Oh,
Okay, I was saying that that's a really nice topic, and from what you are saying, I think it's also important to engage the local people, because I think it'll be easier for them to build rapport, and it can be easier for them to engage in a focus group so that we can get very, very rich information, and also enable like a mix of languages during so that people can be free to actually speak their minds during the interviews and actually have a discussion. So that's really important.
Yes, Alex, I think following up from my colleagues, really, your topic addresses one of the key issues in the country, maternal mortality. Now, there's a little bit of story behind. In the past, the maternal mortality slash going on also to, of course, we're speaking about neonates, but in the country it was around 556, so 556 maternal deaths per 100,000. And the recent report has shown that we have had a drastic decline in the maternal mortality, close to around, I think, my colleagues will correct me, but it's around 104 or 114 maternal deaths per 100,000. So we can all agree that maternal death are not acceptable, but I think your study now will really tell us and it will give us maybe a trajectory to what can possibly be done, like to try to make it a little bit lower, because I know the WHO target is close to 70. By 2030, we are very close. So nice presentation, and I'm looking forward to seeing where this goes. Thank you.
Yeah.
Yeah, so thank you, Lexi, for the nice presentation. Yeah, so I'm not that much have enough knowledge about the maternal health, but I think it's good to think about the to be optimistic and be pessimistic. I'm trying to think about the challenges that we might come across during the study implementation. So the only thing that I can anticipate is to the way you are going to recruit your participant to interview. You may need to have people work in that field for a long time, purposively to be able to give you what are the barriers and what are the facilitators. So I don't know how many people are there, but hopefully you're going to get those people who have a long-term experience. Another thing is I'm also agree with Edwin that for the triangulation purpose, we may need to include other people here to get what they are thinking, what are their barriers and facilitators. Okay, thank you. Thank you, Lexi.
Thank
thanks,
you.
Tim. Any other feedback? Or Lexi, do you have any other particular areas of concern?
I don't think so. I will say that the comments on making sure that we have the correct language in the focus groups. They will be conducted in Kiswahili, so hopefully that mitigates some barriers. And I believe Rosalia will be leading some of those. She can correct me if I'm wrong, but I will not be leading them because I don't have the the language to do that. But I will still be there for support in field note taking.
That's great.
Can I call out William's question in the chat? Lexi, we might need a framework to think through your research question. William, can you tell us more?
I think Lexi, because she's evaluating mainly the barriers. Like, I think we need to have maybe a determinant frameworks. I think just to help us think through a research question. I don't have mine now because the presentation is really quite brief, but I would maybe think together with Leska on really how we can find a nice framework to answer her research question. And at this point, I think we could use a determinant framework in the process. Yeah.
Yeah, perfect. So William, I will echo exactly what you're saying. So the concept here, Lexi, that William is bringing up is that as we're collecting qualitative data within a framework of implementation science, we want to make sure we're thinking about all of the different opportunities of where barriers or facilitators are. There might be a topic that is out there in the literature that we just don't think about. And that's why we use a framework, because it gives us all the possibilities, and that is evidence-based, and that is in the literature, and that's been peer reviewed, and people have put a lot of thought into them. And it allows us to make sure that our questions are fully realized and thought about in comparison to others who have done this work before. And so the framework that William is suggesting would be a determinant framework, and these would be frameworks that specifically help us understand what the determinants are, meaning the social determinants of health, and things might be affecting our patients based upon the question we're asking. So great job, William. Really great way to bring up some implementation science work given your current work. And we're happy to help you find a framework there, Lexi. The 3 delays framework is one that's happened before in access to care for pre-hospital care, and that might work, but there might also be some, and that's been used within the maternal child health environment, but there also might be some other ones that are more deterministic or specifically focused on different determinants, whereas that one is more of a time frame component. Great feedback, William.
Yeah, thank you for that insight. I'll definitely look into that.
Lexi, just one thing I would add. This is Liz Keating, and great presentation. I'm really excited about this project for you. Just one thing I would add as a non-Tanzanian person, I found during focus groups, the more I can make myself less visible, the better, and really rely on our amazing Tanzanian colleagues who are doing the research to speak with their colleagues and really get into the rich data. And so especially if they're in Kiswahili, you're probably not going to understand everything. And so, taking field notes, watching the different, the gestures or the, things that are happening during the interview, or the focus group, but also kind of just trying to maybe blend in with the wall a little bit. That's what I tend to do, and I've had success with that.
Okay, good to know. Thank you, Dr. Keating.
Of course.
Another thing I wanted to point out that I put in the chat, well, 2 things I put in the chat. I put in this paper, which is a few years old now, but you might find it interesting for your work, was something that one of Catherine's mentees, Catherine, I think, Temi, worked on. This is one piece of a bigger work that she did on palliative care in this same, in Moshi. So take a look at that if you haven't already. You might find some interesting other citations there. But also I wanted to point out the reporting guidelines. This is, I see you already gave a reaction in the chat, but this is good advice for anybody in the early stages of a project, whether you're planning data collection like Lexi or in the writing stage, the earlier that you're consulting and really going through piece by piece these reporting guidelines, you're going to set yourself up for success. A lot of us make the mistake of referring to the reporting guidelines when we're doing the reporting, meaning when you're going to publish your paper and you're saying, oh, where did I report this or that? But it turns out, oh, I didn't document this well, or I don't really remember because it was months ago or years ago that I made this decision. So if you can use that as your guide to like writing the protocol and conducting the study, it will set you up better because you'll make timely documentation and kind of have all your ducks in a row, make sure you're doing everything according to the best practice ahead of time rather than having to go back and think about it later. I also wanted to give an opportunity if anybody can share. I know that Charla has lots of insight on this, which I'm sure she's already shared or she'll continue to share about the sensitive nature of things, and you know going into this that this could have some consequences for the participants and the personnel who are working on this study dealing with heavy subjects. So I wanted to open up to some of our folks who have done this kind of work in this setting, but also in others, on advice for dealing with when you might be opening up a Pandora's box or potentially re-traumatizing our research participants or our staff. Advice that folks have. This is a big thing for our qualitative research projects, but it could also be in quantitative research. So if folks have experiences to share, I know some of you do in particular. Welcome.
I can start, and then whoever wants to chime in can. It's nice to meet you, Lexi. Great presentation. So I think when you, similar to what Winnie was saying, in focus groups, you really want to make sure people feel comfortable speaking, especially when it's a sensitive topic. Because if you think about asking a healthcare provider about basically them losing one of their patients, right? That's really sensitive. There may be shame around it. Maybe they feel like that you think they've done something wrong, right? Or that you want to learn from their quote unquote mistakes. So it can feel really vulnerable to ask that question to someone who really tried their best, right? And depending on where they are and their maybe understanding or processing, they may or may not have come to a place where they can really openly talk about this. So in focus groups, I agree. I think groups can really help normalize conversation around that, and that can be super powerful. And at the same time, I think we also need to be careful to not make them feel like we're singling somebody out to talk about their very personal, potentially like painful experience. So one way to navigate that is in focus groups to very much have kind of like a solution focused aspect, right? So that you're asking for their experience or their input on how to improve things, right? So if you wanted to provide the best possible care, how would that look? Because at the end of the day, it's not all that important for you to understand what that one person specifically has done, but rather what they've learned from it and how they would do things differently, right? And that's where the implementation science kind of comes in, because you want to think about what solution you're trying to get to. So talking more about really making sure that they understand you're asking for their expertise to build something that can hopefully avoid that from happening in the future, or build networks that they or the ones after them don't have to go through such a painful experience, I think can be really powerful, so that like you're explaining to them a little bit more and you're including them in that process, right? Of saying, hey, like, this is what I'm doing with your information, right? And you're fully in control. Like, you can tell me how much or how little you want. And that's where it really comes to what Frida was saying too about like audio recorders or something, right? So really making sure how can I make that situation as safe as possible? It might be that you have somebody who's saying, I'd love to talk to you, but in no way will I want to do that in front of a group. Maybe then you want to have a one-on-one interview, right? It might be that they say, I would love to do that, but I only talk with other nurses in the room. As soon as there's a doctor as well, I feel intimidated, right? So understanding kind of some of those potential power dynamics could be also really important. And having those ideas and your plans, have them be looked at by a psychologist at KCMC. Ask them for for understanding and support. I think would be useful. The other thing that I just wanted to mention, since it's your master's thesis, if I understand correctly, you're going to be having 60 focus group discussions that you're planning on doing
Yeah.
just for your thesis.
Yeah.
I would say, honestly, if you have 16, that already would be a ton. So don't conflate qualitative with quantitative research. You don't, maybe start with not 20 facilities, but maybe 3, right?
Yeah, I think um since it is a part of a larger project, if I'm not since I'm only going to be in Kilimanjaro as well for 6 to 8 weeks, if I'm not able to reach all of those facilities with the team there, then I'll use what I can, I think, and then the extra will go into the bigger picture project eventually.
Yeah, I would then maybe plan, and that's something you can discuss with Charla, but maybe plan in step and phases, right? So that you say maybe the first phase is to do the 2 main, or maybe start with one facility and say, how is everything working? Do I need to change something in my approach? Right. And then you say, maybe if I'm able to, I'll do another facility, but being mindful and strategic about how you want to kind of ramp this up, so that you don't stand there and say in your, thesis defense, well, those are all we got to, but there isn't necessarily a rhyme or reason in terms of, well, I chose this one first because X, Y, and Z. Then we went to this one, right? So maybe thinking a little bit about the plan, because 20 facilities and 60 focus groups is a ton. And you may not need, honestly, you may not need that much to get the saturation of the information you need. Most likely you don't.
It's very likely more than enough. Like you'll see, just as an example, the study that I referenced earlier, it had 13 focus groups discussions, which included more than 100 people altogether. That's a lot of perspectives. And also, to part of Anna's point, I think there was something under the surface that maybe wasn't coming out explicitly. One thing about doing it in phases is it's going to be ideal if you're going to be able to do things iteratively. So if you're going to be able to work closely with Rosalia, and this doesn't have to be like onerous. Sometimes people think of it as, oh, if I want to make changes, I have to do the data collection, transcribe it, translate it, and then read it and make changes. It could be as simple as debriefs, or sometimes we have kind of like summary documents from each discussion. And you and the data collector maybe go through those with the PI and say, hey, I don't know if we were getting at this particular question. Maybe we need to shift our questions a little bit more, because another common mistake is we have our interview guide or our focus group discussion outline. We're going to go and collect all the data, and then we're going to analyze it. But then we realize, oh, we have this hole in the data. So that's another reason why Anna's suggestion would be very useful. Any other final comments or questions? Anything to add for Lexi? I'll just say personally, I think it's very clear in the few interactions I've had with you and in your presentation today that you're being very proactive, and you're probably a little bit ahead of the ball compared to some other folks that we've seen in this position. So kudos for thinking about potential challenges before they arise, and best of luck. If folks have comments for you, you're on our Teams channel, right, Lexi?
Yes.
So we can connect there if folks have other feedback you want to share personally, or if something maybe occurs to you later, some information that you have. But thanks so much for sharing, and again, good luck.
Thank you.
Great job. Oh, there's another comment in the chat. Great, thanks, Catherine. And let's thank Lexi for the great presentation. All right.